CataractCoach.com. An experienced surgeon is asking for help. He says, I'm in practice 30 years, but a cataract surgery still takes me 30 minutes. We're watching the video of this surgeon. It's 4 times normal speed. The unedited video was 30 minutes long for routine cataract. And the surgeon's done thousands of surgeries, and the surgeon is 30 years in practice. So the surgeon finished his or her residency training program about 30 years ago. Now let's talk about the good things. Looks like a pretty good draping here. Incisions look okay. We'll take it at that. But what is the delay here? Why does this routine case take 30 minutes? So this surgeon is asking for our help. And I'm going to ask you to please only leave constructive, helpful criticism in the comments below. No negative comments, please. This surgeon is asking for our help. He or she has struggled for 30 years, never really enjoyed surgery, had a tough time doing it, and now still does cataract surgery, not a whole lot, a few cases a week, but every single case takes 30 minutes and every case is stressful. So the rexus is done. That looks pretty good. Here's the hydro dissection. So no real issues with the incision or the rexus, but what else is going on here? So we're about 1.5 minutes into the video, which means in real time, at normal speed, it's about 6 minutes in, which is reasonable. Here comes a phaco probe. Let's see what's going on here. So let's watch the technique here. So looks like a groove down the middle. That groove is okay. So keep grooving. So again, when you do the grooves, you probably don't need more than just a few passes, 3 or 4 passes, maybe 5 passes. This looks like a lot of passes, like 20 passes. So I'm not sure if you're not scooping deep enough or taking out enough material or not confident enough. And then you need to widen up the groove also. Let's see, chopper going in. Again, that ball tip chopper, not a fan, but okay. And now a little bit of a crack maybe. And then grooving again, more and more and more grooving. So again, too much time to me spent doing the grooving on this one groove. That's like 30, 40, I've lost count, 30, 40 passes of the probe back and forth. And now trying to crack again, still not a great crack. So now rotating it 90 degrees, okay. Is that a chop? Hey, a little bit of a chop, okay. Listen, I give the surgeon some props. You're learning some phaco chop here. And let's see, can you get some pieces up? That looks reasonable, okay. So my only fault so far for the surgeon is maybe too much time on that groove and not enough effect on each pass for the groove. The chop looks reasonable. Eye's not in primary anymore. But okay, taking the pieces out. Again, it's all pretty reasonable, not terrible here. I'm still thinking we're okay. Now, there's one thing that we don't want to admit. And we live in a crazy world right now where we all think that everyone's born equal, but we know the truth. I mean, there's this bell curve of surgical skill. And even if you're on the bottom half of the bell curve, I tell you, don't worry. If you have that drive and determination, you can definitely improve and become better. But the catch is, there are going to be some people who are naturally just brilliant at the technique here. Like no matter how hard I practice at basketball, I'm never going to be as good as someone who just has some natural skill here. And again, it's not politically correct to say that. It's a tough thing to say, but it's sometimes the truth. So surgeon's doing okay here. Is that the tubing coming in the view? What is that? What's that white stuff at the top of your screen there? So again, some chop was done, pieces are removed, but the problem is just a kind of lot of flailing around inside the eye. Nothing's really happening. Again, this is 4 times normal speed. The clock says 4 minutes on your video, but that means 16 minutes in. So finally the nucleus is out of the eye. Again, very inefficient technique. This patient's going to have a lot more inflammation post-op. So now cortex removal, again, I like a circumferential approach. I think you'll be a lot more efficient there. Let's take a look. And you're doing okay. So my advice here so far is when you make your beginning of the case is okay, I'd make the rexus a little bit bigger than you've made here. It's a little bit small to me. When you make your grooves for your technique, please do fewer passes. You don't need more than 4 or 5, maybe 6 passes of the phaco probe to get a sufficiently deep groove to crack, not 20 or 30 passes of the probe. So, okay, that's cleaned up pretty nicely, getting the cortex out. Again, all looks pretty reasonable. Oh, there's a big sub-incisional piece there. So you want to go back and get that out. Don't leave that. That's a huge piece. So looks like, transformer eye hand piece. Okay, we like that. That's a good move. I'll give you that. Good job. Taking out that sub-incisional cortex. But I feel a little bit bad in my heart. I mean, this poor surgeon, he or she has suffered for 30 years, saying that going to the operating room was always a stressful day and not an enjoyable day. And then in 30 years, they feel they haven't really improved much in their surgical skill. So it's a tough thing to address here. So filling up the capsular bag, again, a little small on the rexus, that's not too bad. Maybe polish up the capsule a little bit here. Let's see what we got. Okay, checking the pressure. I don't know why. That's an applinator to check the pressure. Barokeratinometer, looks like. And now, what's going on? Lights off. Maybe loading up the lens. So in some situations, you may not have a scrub tech who's going to load the lens for you. In that case, maybe you'll turn off the microscope lights as you load the lens yourself. So now coming back here, let's take a look what's going to happen next. Again, we sped the video up. This is way past 4 times, by the way. I've really just not time to waste here. So this is about 8 times, 10 times speed. But okay, capsule polishing with a capsular polisher. That looks pretty good. Polish that up pretty nicely. Flip it around, do the other way. And let's see the other side. Okay, so capsule's nice and clean. Let's get the lens in. But, again, this eye's been open for 30 minutes total. So you're going to have a ton of post-op inflammation. This is not going to be a quiet eye tomorrow on post-op day 1. So delivering that lens, there's the lens going in the capsular bag. It looks like a single-piece acrylic monofocal lens. And get that in the capsular bag. That looks pretty reasonable using some sort of hook here, coolant hook maybe. Get that rotated around a little bit. And now some cortex removal. Let's see. Viscoelastic removal. Let's see, going inside there. You want to go behind the lens or not? Maybe not. So I appreciate you asking for help here. My advice to you is study our videos on Cataract Coach, improve the capsular rexus a little bit bigger, improve your grooving technique. Overall, you should watch our efficiency week. And please, in the comments below, you guys, please leave your comments. Help this poor surgeon out. Let's help each other become better surgeons. Thanks for watching.